Okay. Uh, so on behalf of Pune Knowledge Cluster, I welcome all of you to this program or to this course of understanding and exploring epidemiology. So this is a 12 session course, having like 2 sessions are there for every week and 6 weeks and so on. So I would now call upon Professor Ajit Kembhavi. Professor Ajit Kembhavi is former director of Inter-University Center for Astronomy and Astrophysics, which is IUCA, and he is the PI or the principal investigator of Pune Knowledge Cluster. So over to you, sir, for the introductory remarks.
Thank you very much, Prachi. I'm very happy to welcome all of you to this first lecture of this course on understanding and exploring epidemiology. Now, the Pune Knowledge Cluster has got a highly structured capacity building program, and as a part of which we organize lecture courses on a number of topics. So we have explored many topics in biology now and also information technology. And the very first course that we organized was by the Serum Institute of Pune. It's called Serum Institute of India, Pune, and which was on vaccines. So then after going through various other topics, now we are back to diseases. So it's epidemiology. The coordinator of this course is Dr. Aarti Nagarkar, whom we'll be meeting in the course of these lectures. She is from the Health Science Department of the SP Pune University. So this is a collaboration program between the Pune Knowledge Cluster and Pune University. So all our lecture courses generally are collaboration between either two institutes, PKC and some other institute, or PKC and some other industry, because it is our mandate to bring together people from different institutions and different industries to work for the betterment of the city. So there'll be other people talking about the course and the speakers, etc. here after me. So I'll be very brief. Just to say that the first lecture today is the introduction to it all by Dr. Doke. So he'll be introduced to you by Dr. Nagarkar. So I again welcome all of you, and I request you to attend all the lectures and participate actively. We would have very much liked to have hands-on sessions associated with these courses, but unfortunately that has not been possible because of the pandemic. It is possible in IT-related fields because one only needs a laptop at home to do that. But in this case, there will be visits to places. And we will arrange them later in the year, hopefully, when the situation is much safer. Thank you.
Thank you so much, sir. And I now request Professor Surendra Bhaskardvi. He's the senior advisor at Pune Knowledge Cluster, and for several years he was at Agarkar Research Institute, to introduce Dr. Aarti Nagarkar.
Thank you, Prachi. Good morning to all of you, and welcome to the course. We usually, approach experts in the field to try and organize courses which are going to be useful to students and young PIs. And in this case, when I approached Dr. Aarti Nagarkar, she readily agreed to work on this and has put together an excellent course. So first of all, I thank her very much. I also thank all the participants and my two colleagues, Prachi and Shilpa, who will be handling the logistics parts of this course. I thank them also. They are the essential part of this course. Dr. Aarti Nagarkar did a MA Anthropology from University of Pune way back in 1992. And then she worked for a doctoral degree also at University of Pune and got a degree in 2001 in medical anthropology. She joined the university as assistant professor in 2009, and currently since 2018, she is the head of Department of Health Sciences and director of the Interdisciplinary School of Health Sciences. She's been teaching for the last 20 years in the MSc Health Sciences and Master of Public Health courses. The research areas of her interest are, in broad terms, they are social determinants of health, with specific reference, special interest in aging, functional decline, frailty, and disability. She supervises PhD work. She's already there are 3 people who have already completed their PhD degree with her. 4 more are pursuing that. She has also supervised many master dissertations because that's a part of the curriculum of the master's course in SPPU. She has 4 active international and national grants. And she has several publications, over 30 publications, and she has also edited a couple of books. So she's very active in this field, and I'm very happy to say that as I approached her, she readily agreed to put together this course, contacted stalwarts in the field, and most of them have agreed. And you will see that it's a very impressive program that we will conduct over the coming 6 weeks or so. We have purposely kept it not a continuous lecture course, not one lecture every day, but we have kept a couple of lectures every week so that you have time to assimilate and also come up with suggestions and questions for the organizers as well as the speakers. And our team, Prachi, Shilpa and others at PKC, will help you get in touch with the speakers as well as the coordinator. So thank you, Aarti, once again for readily agreeing to, put together this course for PKC. And just last point is that although it is Pune Knowledge Cluster is for area around Pune and Pune and surrounding areas, because of this online mode of organizing the courses, we have been getting applications from various parts of India as well as from outside India. A course that we recently conducted last month on plant breeding people applied. People from 25 countries other than India applied, and many of them participated. Over 700 of them applied. In this case too, we have over 250 applications, and we have taken a call on that, and then we have actually admitted all of the participants so that maximum persons benefit from this. And as Ajit mentioned, since we cannot have a hands-on component at the present time, we thought that the benefit should be extended to all the interested people here. So thank you, Aarti, once again, and I hand it over to you to take over from here. And as I said, we all at PKC will be there to help you with the logistics, including the question answer session. And I welcome Professor Doke for the very first talk. Over to you, Aarti.
Thank you, sir. And thank you for such a generous introduction. Good morning to all participants and the speakers. Thank you for your interest and joining the course. I'm from Pune University, and every year we receive more than 300 applications and we select just 20 of them. So I feel that this particular course or offering this particular course will help us to reach to many more who have been denied opportunity in last several years. So the purpose of this course is to sensitize students of life sciences and to the scientific methods of disease investigation. As you probably know, that epidemiology is highly interdisciplinary science, and it requires support of laboratory scientists, statisticians, social and behavioral scientists, and of course, other healthcare professionals. The current pandemic is an excellent example because this is very unexpected event, but it has helped us to understand that epidemiology directly impacts our lives, and our reliance on it will only increase in changing world. At, as some of you are already know, that epidemiology identifies the distribution of diseases, factors underlying the disease source or causes, methods for their control. And this requires an understanding of how political, social, and scientific factors intersect to aggravate or to reduce disease risk, which makes epidemiology a unique science. You will learn more about epidemiology in next 6 weeks from 10 different experts. The idea is to expose the participants to the beauty of science of epidemiology and the interdisciplinary opportunities it may offer to those who want to venture into the field of health. We do not claim that this course will make you an expert epidemiologist, but the course will tickle your mind and it may help you to shape your career, your future research ideas. Today, we are opening the course with Dr. P.P. Doke. And I'm very happy to welcome Dr. Doke over here. Dr. Doke is MD, DNB, and PhD in epidemiology. He has received training from the USA, Germany, and many other European countries. As introduced earlier, that he is retired as a director of health services after extensive more than 23 years of service with the state government of Maharashtra. And after that, he has worked as an executive director of State Health Resource System Resource Center. Currently, he is fully engaged into teaching and research. He has been teaching in many medical colleges and universities in Mumbai as well as in Pune. Although he likes to talk about public health and epidemiology, but we at the School of Health Sciences, we are benefited by his experience in administration, and he used to teach management of health services in school. And we still remember some of his lectures over there. Dr. Doke has several publications, including journal articles and books, and he has many awards to his credit. With this introduction, I just want to say last few words that one of the qualities epidemiologists must possess is clarity of concepts, as this helps in clearly communicating or teaching with the people or students, especially students who come from diverse background. I'm happy to welcome Dr. Doke. We could not have got better person than him to teach fundamentals of epidemiology. So I thank you, sir, for accepting our invitation. And I'm sure the participants will enjoy today's session as well as session that is planned on Friday. With this, I welcome you once again. I welcome all participants and hand over this floor to Dr. Doke. Dr. Doke, over to you.
Thank you, Dr. Ardi. Good morning to all colleagues. This is a nice opportunity to have interaction with colleagues almost nearby countries and many from other parts of Maharashtra, India. So for about maybe 50 minutes, we'll be discussing about basics of epidemiology and public health. So in brief, I will be giving some information about history of epidemiology, then the definition, contents of the definition, and we'll proceed accordingly. We are proud that there are two similar words, epidemiology and epidemics. They are not only similar, but they are interrelated. Most of the epidemiological knowledge pertains to epidemics, but by passage of time, this has been applied to many other problems, not only for medical sciences, but even for veterinary sciences, plant sciences, etc. So in Ayurveda, there is a word called Janapada Vidvamsa. Janapad means masses, Vidvams means abolition or devastation. So this in short is nothing but large epidemic. The large epidemics have been described in Ayurveda, and more than the describing epidemics, the causes have been beautifully described. Similar causes of epidemics are quoted by Hippocrates. The treatise for which he is famous is on airs, waters, and places, which means that epidemic can be attributed to bad air, bad water, and bad place. The same concept of Janapada Vidvams. So, is it only epidemic that are associated with this air, water, and places? No, not only epidemics, but our health is all related to this. This was in the recent past, John Grant he published nature and political observations made upon bills of mortality. I am sure some of you must be knowing what is bills of mortality. In British Parliament, weekly they publish data of deaths and it is submitted to the Parliament. And he was the first man to analyze what are the causes of mortality, and he brought quantitative methods in describing population vital statistics. So we call him the first demographer. Continuing in the history, John Snow, who is called as father of epidemiology. In 1850, imagine, he has most beautifully demonstrated how cholera spreads. At that time, the organism Vibrio cholerae was not known. Still, he draw a plot, what we call as the spot map, then epidemic curve, etc. And he directly proved that this cholera is due to contamination of water. So coming now to the actual definition. EP means among, demos means people, and logos means study. At the brochure, it says that epidemiology is the study of distribution and determinants of disease frequency in population. This is the best and very precise, simple definition. Study of distribution and determinants. When I say these two words, which have been given in red, distribution means measurement. Measurement across in the context of some other variable. And determinant means what are the causes of that distribution. So in short, it has two basic concepts: measurement in the different context and the causes of that particular distribution. The latest definition given by in the dictionary of epidemiology, that is the same but extended. The study of occurrence and distribution of health-related events, states, and processes in specified populations. It includes the study of the determinants influencing such processes and the application of this knowledge to control relevant health problems. So again, dissecting the definition, what study means? Study means surveillance. Surveillance is collection of systematically data, observation, screening for diseases, primary screening, hypothesis testing, all epidemiological analytical research, experiments, and most important is prediction. Distribution means it refers to the cases by time, place, and population. It classes of subgroups of persons affected in an organization, population, or society, or at regional and global scales. And I believe the third is very important. Determinants are the geophysical, biological, behavioral, social, cultural, economic, and political factors that influence health. What do you mean by health-related events? As I said initially, it was started with epidemics, infectious diseases, and later it is extended to non-communicable disease also, syndromes, causes of death, behaviors, why people drink, why people smoke, environmental and socio-economic processes, the effects of preventing programs, and use of health and social services. This all has a denominator, specified population. All this distribution relates to some geographical or defined population. And most important, and which is stated lastly, this is not a basic science or basic research. Epidemiology is always applied science. This all has to be done for application of control. It makes explicit the aim of epidemiology to promote, protect, and restore health and to advance scientific knowledge. I love this poem from Rudyard Kipling, Nobel laureate. I am sure you must be knowing who wrote the Jungle Book, which was very famous among kids. What the poem says: I keep 6 honest serving men. They taught me all I knew. Their names are what and why and when and how and where and who. I think this is in the gist how we can acquire knowledge about disease or any health related problem. Why, what, why, when, how, and where, and who. If you answer this question, the whole scenario will be crystal clear. There are two angles. The first angle is measurement, and the second angle is what are the causes of that particular problem. In the measurement, we use 3 words. I am sure you know these words: endemic, epidemic, and pandemic. Endemic means all throughout year few cases occur indiscriminately. Few cases occur throughout year indiscriminately. The disease is called as endemic. Epidemic is a large number of cases, more than expectations, in a localized community in short duration. And now coming to the pandemic. Because of COVID-19 pandemic, we are all aware about the word pandemic. Pandemic is more than 2 continents are affected. At least 2 continents. Now, in COVID pandemic, the whole world, about 250 countries are affected. So this is the word pandemic. In the measurement related to disease and related to health conditions, there are 2 major groups of indicators. These are called as morbidity and mortality indicators. I will like to clarify the difference for my colleagues. What are these 2 sets of statistics? Morbidity statistics, there are difficulties in diagnosis. To give example, what is anemia? Is it 10 gram, 11 gram, 8 gram, 5 gram? So there are diagnostic difficulty. Even in pandemic, what is disease? Is it rapid test positive or RT-PCR positive or high density CRCT positive? For every disease, there will be diagnostic difficulties. Then a person can be exposed many times. So how you call infected person or episodes? That creates problem. The data may not be available, particularly when the disease is mild. Then individual and episodes. I was saying that what we count to individuals or episodes and time frame. But in mortality, comparatively, this study is easy. The reason it occurs only once. It is unequivocal. Everybody is sure about that, and usually reliable data are available. So these are the 2 sets of studying any disease or any health related conditions. In the mortality statistics, we have many. I will just name few of them. Crude death rate without any specific age group or any specific disease. Specific death rate, case fatality rate. In COVID pandemic, we are aiming to have case fatality rate less than 1, which simply means if there are 100 infected persons, how many succumb? That is called as case fatality rate. Proportional mortality ratio. This is a way of expressing what is most prevalent today. Suppose now 100 deaths are there. What is the commonest cause of death? What is the proportion of commonest cause? Proportion of commonest cause of death is pneumonia. So which means that out of 100 deaths, pneumonia is responsible maybe about 8% cases. So that is the top cause. Survival rates. This is used exclusively for long-term diseases. Cancer. How many cancer patients survive 4 years, 5 years, 10 years, etc. And the best is life expectancy because it is impact of everything together, life expectancy. It is the other way of mortality, the other side of coin of mortality, but it explicitly nicely a total comprehensive indicator. I will not go into the standardization, but these rates are to be standardized based upon age and sex of that particular population. Few clarification I feel I must give because they are many times confused. A ratio is one number relation to another number. Relation of numerator with denominator when both are mutually exclusive. To give example, sex ratio, number of females per 1000 males. So 1000 male, how many females are there? That is mathematical relationship between two numbers. A proportion indicates the magnitude of numerator and the denominator usually considers 100, 1000 or 10,000 or 1 million, whatever is that depending upon the scale, the number of the numerator. Here the best part is numerator is inclusive of denominator. The rate indicates how fast an event is occurring. The numerator is a part of denominator like proportion, but here what is more important is that includes unit of time. So 6 deaths are occurring per 1000 population in a year. That is the complete definition having three phrases: numerator, denominator, and unit of time. Index, we many times use this word index. The best known index is Human Development Index. This is amalgamation of few proportions with or without weightage. So we must be clear about these terms when you describe any measure of any problem. We just describe what is a rate, how fast a thing is happening. And the best example of rate is incidence rate. The act of happening and the occurrence of extent of frequency of occurrence. Count of new cases over a period of time in a population. You can get this obtain this information from disease register or a cohort study or a trial. There are two key formulas: the new cases per unit of time and divided by population at risk. Here, I want to emphasize that the denominator is population at risk. There is no point measuring incidence of COVID-19 among vaccinated people. So it doesn't become incidence rate. It becomes a breakthrough studies. So if the denominator is not having risk, incidence rate should not be calculated. There are other measures. Secondly, incidence is best suited for acute conditions, short-lived conditions. The other word used to describe measure of a disease is called as prevalence. Prevalence is count of cases, new and old, at a given point in a population. It can be obtained from cross-section studies or disease register. Actually, it should be a one point, specific day. But number of times, unless God, we can't say what is the number of COVID cases today at 11:20. So we consider 24 hours. Many times we consider 1 week, but basically it represents a specific time. The formula is all cases and population at risk. This is better suited for chronic diseases like leprosy, tuberculosis. So prevalence, number of existing cases, new and old, divided by population at risk, and you may express per 100, per 1,000, depending upon the nature. So this is one of the beautiful slide I love that gives clear information, pictorial information, what is the incidence and what is prevalence. In the tank, incidence means new cases in the community, prevalent means all cases. And from prevalent cases, deaths, immigrants, and recovery, they are subtracted from the population. But friends, it is not as simple as that. New cases, prevalent cases, cases coming, cases going out. There are many other scenario and it becomes complex. How it becomes complex? So there will be new births in the population. There may be immigration adding to the population, and recovered patient also come again. The recovered patient may be susceptible, may not be susceptible, depending on the condition. And the population, again, incident cases go to prevalent cases. From the population, immigration of cases, unmeasured cases, occurring cases abroad, and deaths. So out is recovery and out is immigration, non-measured case and deaths. So this is more or less a realistic picture which happens in the community. So what is relationship between these two? Why I'm stressing on these 2 points? Because these are the most important point of measuring any disease. If your objective is to know what is the cause of disease, the incidence rate is preferred. The study of burden of diseases of short duration like measles, incidence is also preferred. The prevalence rate is generally preferred as the measure of burden of long-lasting diseases. I have given 2 examples, tuberculosis, leprosy, and cancer also. For health behaviors and other disease risk factors, prevalence is preferred measure even in the studies of disease causation or behavioral sciences. Continuing this discussion ahead, in a fixed population, the prevalence is equal to the incidence rate into average duration of disease. Consider number of cases, X number of cases of tuberculosis. They will be there for 2 years. So prevalence is incidence plus 2 years, that gives you total cases. It follows that incidence rate is equal to point prevalence is divided by duration, and duration is equal to point prevalence rate divided by incidence rate. So the message to take home is that they are interrelated, and the point is how long the disease stays. In a dynamic population, however, the prevalence of a disease cannot be predicted from knowledge of the incidence or vice versa because of migration into and out of population, deaths, changing disease rates, changing in prognosis and error in measuring the incidence. In practice, either the prevalence or incidence are usually measured, but sometimes both can be measured. The other point is that Dr. Arti was also mentioning epidemiology is multidisciplinary applied science. It's a multidisciplinary and applied science. What are the disciplines which help in carrying out epidemiological investigation? The first is, of course, disease investigation, then medicine, statistics. Nowadays, in COVID pandemic, the statisticians and particularly computer sciences, developing models, etc., are giving extensive help in prediction of the disease. And because epidemiology deals with masses, with large numbers, it is has to be supported by statistics. Social sciences, investigation of human behavior in relation to disease, and methods of data collection. To continue the same example of today, how we behave, like social distancing, mask use, avoiding crowd, taking vaccination, all these are related to social sciences. I was telling about computer sciences, statistics, modeling, and artificial intelligence. All these are related to epidemiology. And managerial sciences, acquisition of grants, research collaboration, management of clinical trials. This is all managerial sciences. And lastly, the newest addition is genetic sciences. For every disease condition now we are searching the reason in genetics. And many times we could find many times today, many times this is not the proper time. Maybe in future we can have the attributing genetics also as one of the cause for most of the diseases. So in short, these are the disciplines which help. This was all about the first part of epidemiology, measurement. You have to measure how the problem is there in the community. And the second principle in epidemiology is that for any health problem or any disease, there are multiple causes. And these are called as the determinants of that distribution. We have studied about distribution of disease. So in determinants, in the history, I am only giving few examples. This dates back to 1842. Report of the sanitary condition of laboring population of Great Britain. It was published in 1842, describing the horrible situation of laboring population. At about the same time, Lemuel Shattuck, he also published a report on the Sanitary Commission of Massachusetts City in 1850. The reasons for ill health at that time was mainly due to bad sanitary conditions. I am again repeating, all ill health at that time was related to bad sanitary conditions. The other determinants, apart from sanitation, I sincerely request my colleagues to have a browse on these two reports. One is called as Black Report, Department of Health and Social Security. Now the Department of Health and Social Care in the United Kingdom. The report was submitted by Sir Douglas Black. The report clearly says that all the diseases and particularly mortality is differentially distributed in social classes. We know socioeconomic status based upon occupation, income, etc. And in this socioeconomic status, there is a drastic difference in illnesses and death rates. The poor, lower socioeconomic status, and this is a latest one in last decade. Earlier was 1850. This is the latest one, Black Report. There is another one by Thomas McKeown. We, doctors particularly, we take pride in saying that we have almost conquered many diseases and the life expectancy has increased to 70, 80 in various countries, up to 90 in Japan. But Thomas McKeown, he analyzed the trend from 1700s until 1918, 1990. He was publishing articles very vehemently saying that it is not the medical science, but it is the broad economic and social changes they have helped to increase the life expectancy. My point is not to argue here. The point here is that there are many other social determinants also, and we have to take cognizance of them. I will take one more example. The disease tuberculosis was almost eliminated in UK before any anti-tuberculosis drug, before advent of any anti-tuberculosis drug, only because of better sanitation and socio-economical changes. So that buttresses the findings of Thomas McKeown. So in short, about epidemiology, basic epidemiology, patient-doctor relationship is for individual problems and epidemiology is for masses, for whole the community. And the reason is that the problems in the community, the context differs. The sequence of epidemiology measure the problem and determine the causes. Basic principle is that always there are multiple causes by proper analysis. To our students, we always teach them you classify various causes into time, place, person distribution. In the time when the disease is occurring, in the place what genetic makeup, age, sex, etc. By place which country, which disease, which locality is getting affected. And based upon this final analysis, you can draw conclusion. And when you draw conclusion, you can suggest probable solutions. So all this which I described is a rational way of thinking. Because first you have to measure and see what are the causes for it, and these causes are multiple causes. Therefore, as I said that epidemiology is a rational way of thinking and can be applied to any problems, not only health problems. So we'll now go to the second part, basics of public health. Again, public health is defined long back. That is the science and art of preventing disease, prolonging life, and promoting health through organized efforts and informed choices of society, organizations, public and private communities, and individuals. Bill's definition. And still, it is supposed to be the best definition of public health. Again, when we want to dissect it, preventing the disease is absolutely clear. Vaccination, immunization is the major, most important domain of public health. Prolonging the life. Friends, it is not prolonging of the life what you think. A patient who is in intensive care unit is on ventilation, he is on only IV fluids, etc. There is catheter, he is comatose, and such a life can be prolonged for years. We know a case of KM hospital. The lady was almost 40 years on bedridden comatose condition. Winslow didn't mean prolonging of life due to advances in science. Prolonging of life means life expectancy. At the time of independence, our life expectancy was only 35 years. Now it is exactly the double, 70 years. So what is meant then? Prolonging of life, and not prolonging of life, the quality of life. So preventing disease, vaccination is the main forte of public health. Prolonging life, all measures together increasing life expectancy. Promoting health, it is the quality. But most important clause is organized efforts and informed choices of society organizations, public and private communities, and individuals. World Health Organization has slightly different view. It's like I should not say or blame or public health aims to provide maximum benefit for the largest number of people. This is a managerial statement. Public health aims to provide maximum benefits for the largest number of people. What is difference between public health and clinical care? Clinical care is for individual patients. When we feel sick, we go to the doctor. In the public health, population is the focus. Clinical care, it is the personal service ethics. In the public health, it's the public health ethics. Clinical care, it is the diagnosis and treatment is the emphasis. Here, prevention of public health is important. Prevention is emphasized in public health. It is the joint laboratory and patient involvement. It is the joint laboratory and the field involvement. Clinical science essential to the professional training. Clinical science peripheral to the professional training. So main training is different. Clinical science is a small segment of training in public health. Public sector is the basis, private sector is the basis. We'll learn more about this last one. So what is the public health approach? Public health approach and epidemiology, they are almost similar. In fact, they are the supporting disciplines to each other. In public health, we use epidemiological methods maximum. So surveillance, what is the problem? Surveillance is getting close and prompt observation, close and prompt observation to take action. That is called as surveillance. You collect the data, analyze the data, give feedback, and give recommendation. That is the surveillance. Surveillance is a broader term rather than not only notification. The next is risk factor identification. So, as I was saying, it's exactly like epidemiology. What are the causes? What is the problem? What are the causes? And these causes can be determined by different types of analysis. But public health now goes one step ahead. What is that? What works? Out of many attempts, strategies implemented across globe, across population, what has worked and what works. And out of this, you carry out an analysis and then implement it. How do you do it? Implement it. So it is from problem driven to response driven. This is the public health. The core functions of public health can be grouped under three headings: the assessment, policy development, and assurance. Assessment is systematically collect, analyze, and make available information on health of the communities. So in the paper we read there are so many cases and so many deaths daily. That is given in the newspapers, in TVs. That is first is the assessment. What is the level of health of the community? The second is policy development. Promote the use of scientific knowledge based in policy and decision making. Based upon the knowledge, you have to frame the policies, and by framing policies, you have to ensure provision of services to those who need. So, as I said, public health is also applied science. Here, the principle is that what we call as the high risk approach. Those who need more should be given more to bring equity. The same three core public health functions can be further described as essential public health services. The first two, assessment, they can be subcategorized into monitoring health, diagnose and investigate. That is the assessment. Policy development, inform, educate and empower the community. Here I am again reading, inform, educate and empower the community at a large. Then mobilize the community participation. Public health alone cannot be achieved by government or by the officers. It should be always with the community. It cannot be achieved without mobilizing the community. Develop policies. The sixth one is one of the important aspects of public health, which no other branch envisages: enforcement of laws. To change the behavior, the foremost is communicate them, motivate them, but still you find that this is not happening to the satisfactory level, then there is a role of enforcement of laws. Provide care, one of the public health important function is provide care those who need it, those who are ill, assure competent workforce, not only buildings but also manpower, evaluate frequently, as I said, what works best, where it works best, and modify it. And then research is the cross-cutting. These are the public health services. Three core functions which includes 10 health services. Public health is usually a domain of government. This is a rough estimate. Who are the various stakeholders in public health? 85% of public health is through public sector. And as I was saying, mostly vaccination, immunization services, and what we call as primary health care. So minimum and primary health care is the government main role. The next is international organization, roughly about 8%, because UNICEF, WHO, UNFPA, Melinda Gates, etc., they always support, give guidelines and support various state governments and central government. NGOs, non-government organization. There are many small non-government organizations. Many non-government organizations work in for only public health. And then private sector. Public health, as I said, it is not generating any revenues. So public health is not an favored segment for private sector. Career in public health. Medical students usually do not opt for public health as a good option. They always go for their first choice is clinical sciences. The reasons may be lesser earning compared to the clinical branches, but social minded people, those who want to give something in return to community, they get attracted to public health. And the last one is very important. Its importance is realized during health problems like pandemic. In the pandemic now, they are realizing that how important is public health. This is the last slide, I believe. Public health, as Ms. Lowe said, that it is from the community, with the community. like our constitution. There are many stakeholders, doctors and paramedicals, lawyers. Those in history, there are many lawyers, social scientists, statisticians, entomologists, biologists like genetic scientists, and non-medical. Among all these, there should be strong commitment, political commitment, bureaucratic commitment, and commitment from medical and paramedical sciences. If this is achieved, I think we can do the miracles. If you have any question, I think Dr. Aarti will have this question answer session later. Thank you very much.
Yes. Thank you so much.
Thank you, sir.
Yes, Dr.
Uh, Sir, if you have time, then maybe we can have a couple of questions now.
Yeah,
And
sure.
yeah. Says students have asked some questions. One of the question is that how might laboratory scientists be useful in the study of epidemiology? Sir, some of our participants are from biotechnology or molecular biology, basic sciences, or
Yes.
they are doing something in biochemistry lab. So they are interested in this question.
In fact, in epidemiology, particularly when it is an infectious disease and genetic lab,
Hmm.
for a new infectious disease in public health, there is no expertise. They always seek help from biologists and laboratory sciences.
Yeah.
As now we are taking help from, initially it was difficult to isolate the organism. Now we are isolating.
Hmm.
We are carrying out genomic sequencing.
Hmm.
Which genes are changing? Is it responding to the vaccine? So their role is very important, particularly when the agent is new one. That is first thing.
Hmm.
Secondly, role of laboratory is very important when to have a point of care diagnostic.
Hmm.
Suppose now you want to take blood, take it to the laboratory, give result after 4 or 5 days. That is not rational. What we want, what the doctors, what the community want, the patient is there. At the patient side, can you detect the organism? Can you detect his sensitivity to which antibiotic it is sensitive? This is one core area of laboratory sciences. The second core area of laboratory sciences is that, as I was saying, genetic. We know now there are even in diseases we never thought of, like preeclampsia.
Hmm.
The genetic predispositions coming forward, they are trying to explain. So these are the 2, 3 areas where lab science are extremely important. And in the case of epidemic, particularly if the epidemic is of unknown origin, we do not
Yes.
know what is the cause of the epidemic. And
Hmm.
there, laboratory science is of extremely important. We cannot underestimate their role.
Yes. Yes. So there is one more question, which asks, so what are the general guidelines for improving public health? I know this is a very broad question, but
The first one is we must have adequate budget. Every time since I was in services, even later now also, is not me, from National Health Policy, National Health Mission, all these planning commissions, everybody is saying that the budget for public health should be increased. Unfortunately, in spite of the highest body recommending it, it is not happening.
mm,
That is the first one. Second is the excellent training.
mm,
Now this is an area the public health initially was restricted to only medical worker. Now it is open to each and everybody, and their
yes,
contribution is welcome. And there are many who are contributing it. You yourself know how many are students coming from MPH classes,
mm,
and they are very right, glaringly doing their work. So this is the second, excellent training, budget head, and
mm,
thirdly, what you say that the accountability.
mm, mm,
When give them powers, give them money, and then they make accountable. What is happening now? Gradually, the public health domain is getting restricted.
mm, mm,
This is unfortunate, but it's happening across the Indian situation. Rest of the countries, to give example, a public health specialist in Russia and America is a very powerful person. He or she is not that powerful in India. So the policy making, and I have given one reason why it is not there. One thing is that the remuneration he or she gets. So you have to popularize. If you know the importance, you have to make a positive effort that how good people are attracted. When I was regularly teaching long back in government medical colleges, one of my suggestion was that for MBBS candidate, you like engineering colleges, go to medical colleges and offer directly district health admission post to the first candidate. I'm sure many rank first candidate will opt for public health if they are given that they will be district health admission immediately with good salary, and his or her tenure of 3 years will be borne by the expenditure will be borne by the government. This is the way we can provide and increase public health. So in short, these 2, 3 are the ways.
Yes. Sir, there is one more. It's a comment, I would say, rather than a question. Do you think there is a need to have a separate public health cadre in public health services, similar to IS officer?
Yeah. What we are thinking that it was not public health cadre, but it was medical cadre. Earlier also there was medical cadre, and now also many times it go on and off situation of having a separate medical care. But in some states we do have no glorified, but we have a public health cadre. We have in Tamil Nadu. We are partly having in Maharashtra also public health cadre. But see, this is what we call as this is the struggle between the two disciplines. Everybody wants that I should be promoted, I should get the good post. So this is between the disciplines.
Yes.
But as I said, as a public health, as a community, the role is very important. Public health role is very important, not for individual, but for the community.
Community, right. Sir, just one last question, if you permit. And that is, how do we attract private sector into public health? Do you have any idea on that?
The first thing is that the government has to take a call. There are many private organizations who are ready to take over subcenter, PSCs and rural hospital and offer services, good quality services. But then it is like shrinking of kingdom. No king wants to shrink his or her kingdom. So the policy is not yet taken. There is only 1 or 2 examples. I know after Sastur, great the earthquake, one rural hospital has been handed over to NGO. In Karnataka, they have done very nice experiment, Corona Trust. Some of my colleagues must be aware. The Corona Trust is getting good response and giving quality services, public health services. So this decision should be taken and they should most welcome.
Okay.
Rather than total private sector, I am emphasizing NGO sector.
Right. And sir, just one more. Sir, could you just tell the young participants that what are the career opportunities in epidemiology and public health?
Yeah, in fact, now in earlier the department was called as preventive and social medicine, but now it is called as community medicine. And even community medicine, I think there are only 2 very good careers. One is in epidemiology, the other is in health and hospital administration.
Okay.
In future, these 2 will certainly flourish. And for a person who is an epidemiologist, believe in me, in WHO, maximum budget is for health, public health and epidemiology. Maximum research, maximum budget of WHO. I can't tell of others, but in WHO it is there. Our own students who passed before 5-10 years, they have gone to WHO, they have gone to UNICEF, they have a place abroad, having very excellent career.
Yeah.
But don't limit to teaching and don't limit to becoming medical officer. Have an ambition to become international person, and it is possible. There are plenty of examples.
Right. So it depends on how you take your career trajectory
Correct.
and what
And
other interest
secondly,
you have and
yeah,
shape.
nowadays even the clinical trials is an area where they want good statistician or a person, a medical doctor who knows something about statistics. And in these two careers, who fits is the epidemiologist. So
Right.
many clinical firms,
Mm.
they are offering
Mm.
this clinical trial business to epidemiologists.
Epidemiologist. Right. So there are other questions, but maybe during your next session we try to cover some of the
Okay.
questions. And thank you so much for such an
In fact,
informative session.
yeah, in
Yes,
fact,
sir.
I should thank that you have given me opportunity to have dialogue with so many persons at a time. Thank you.
Thank you, sir. Thank you. Sir, we'll see you next Friday at 11
Okay.
o'clock.
Right.
Okay. Thank you, sir.
Bye.
Okay, bye.
Thank you, Professor Doke, and thank you, Aarti.
Thank you, sir.
Thank you, everyone. Friends, we have just put the link of attendance in the chat box. Kindly fill up that. We will be doing this for every session. At the end of the session, when the question answer starts, we will put the attendance link in the chat box. So please keep a look at that. And for the next session, for all the sessions of the course, the same Zoom link would be working.
Okay.
Okay, so kindly
Yeah.
join by the same link. We would be sending reminder emails one day.
Okay. Okay. Okay.
Thank
Thank
you
you,
so much,
Prachi.
everybody.
Thank you, Dr. Gaskadvi and Dr.
Oh,
Doke.
most welcome. Thank
Okay.
you for doing this,
Yeah.
and it has started off well. Thank you, Professor Doke, and let's
Yes.
hope that it goes like this. Okay.
Yes.
Thanks to
Yes.
the participants also.
Yeah.
Yeah. Thank you.
Thank you.
Bye.
Thank you. Bye. Bye. See you on Friday. See you
Friday.
all on Friday.
Yes, Prachi and Shilpa. Bye.
Bye.
Bye.